After we have studied occlusion and malocclusion, its classification, and we have seen the removable appliances, the fixed, the orthopedic, and the functional. Now we can gather these information and see how we can apply them in dealing with malocclusion management. In the coming episodes, we will discuss the management of Class 1 malocclusion, Class 2, Class 3, the deep bite, open bite, cross bite, and the midline diastema. And we will finish by talking about the cleft and the lip and palate cleft. Now let's define the Class 1 molar relationship. It is when the mesiobuccal cusp of permanent maxillary first molar occludes in the mesiobuccal development groove of the mandibular first permanent molar. So, in the Class 1 malocclusion, we see that we have a Class 1 molar relationship, Class 1 incisor molar relationship, but addition to it, we have some crowding, spacing, rotations, bimaxillary protrusion, bimaxillary retrusion, cross bites, and open bites. So when dealing with them, we must maintain the molar relationship to be in the Class 1. Then we do the changes on the teeth only. Now, crowding is considered the most common complaint of the patient seeking orthodontic treatment because it has an aesthetic impact, especially if it was in the anterior region, and it can be associated with Class 1, Class 2, and Class 3 malocclusion. It can be caused by the arch length tooth material discrepancy or premature loss of the deciduous teeth, prolonged retention of the deciduous teeth, presence of supernumerary teeth, macrodontic teeth, delayed eruption of permanent teeth, trauma, and gementation of the teeth. Here we see the discrepancy. We diagnose the crowding by clinical examination and doing model analysis to determine the length and the tooth material discrepancy. We do some radiograph examination to evaluate if there is any trauma or bony pathology or any unerupted teeth. Now for the treatment, it can be done by arch expansion or proximal stripping or using removable appliances like the Jake screw and the Z-spring. We can also do distalization of the molars. In some cases we can extract the teeth. This is the quad helix expansion appliance that has 4 helices, and this is the Jake screw that is used in conjugate with a removable orthodontic appliance, and this is the removable appliance with the Z spring that is fabricated on the lateral incisor, and it starts doing lateral labial movement of the lateral incisor when we activate it until the tooth reach the proper alignment in the arch. As for spacing, spacing is induced by oral habits such as thumb sucking or tongue thrusting and large tongue. It can be lateral or bilateral on one arch or on both arches. It can be localized or generalized. The treatment of spacing is to remove the oral habit using removable orthodontic appliance like this one that is used to intercept the tongue thrusting habit and correct the existing malocclusion. Also, finger springs can be used with labial bow to close the spacing. If you want to use fixed orthodontic appliance, we can use the closed coil spring with elastics. And if the spacing is minor, we can use conservative approach of doing composite resin restorations. Now for the management of class 1 malocclusion with rotation, it is important to understand that the correction of rotation is considered easy, but the retention to avoid the relapse is harder. So the retention is so important when we derotate a teeth. When we do the derotation, we apply a force that is equal and opposite. The supracrystal gingival fibers that are attached to the tooth, when we apply force to derotate the teeth, they take time to reorganize after the deorientation. So they have more tendency to relapse again. So what we can do is to do some fibrotomy of removing these types of fibers to maintain the new position where new fibers will be regrown in the new position of the teeth. And now for the treatment of rotation, we can use the Z spring and activate the upper helix only to get the rotation effect. Also, we can add an expansion screw in the middle with the labial bow for retention. If you want to use fixed orthodontic appliance, we use the nickel titanium arch wire and derotate the spring in the picture that we have shown earlier, this one. Now for the retention. The retention can be done depending on the number of tooth that we want to retain. If we have a single tooth, we can add what is called a band and spur. And if we have multiple teeth that we want to retain, we use a lingual retainer that is bonded from the canine to the canine. If you want to treat multiple rotations, fixed orthodontic appliance is used. We first do an expansion for the arch using the Hyrex to create space for derotation of the teeth, and then we narrow the teeth and align it properly. Now for the management of the bimaxillary protrusion. It is characterized by flaring of both the maxillary and mandibular anterior teeth, with resultant protrusion of the lips and convexity of the face. They are commonly seen in Asian population. What is important to consider that in these cases, the molar is a class 1 relationship, the canine is class 1. We treat these cases by extraction the 4 first premolars, where we need the maximum anchorage. In these cases, we retract the anterior segment or protrude the posterior segments or do a combination of two. When doing so, this is called a maximum anchorage. In this case, we extracted the first premolars and do a retraction of the anterior space while maintaining the class 1 molar and canine relationship. Now for the management of bimaxillary retrusion, where there is a retrusion of both upper and lower anterior teeth resulting in a concave facial profile. It can be treated using a removable orthodontic appliance with expansion screw by activating it in turning to 90 degrees twice in a week to bring about forward placement of anteriors and correcting the retrusion. As for the scissor bite, that is defined as the completely buccal relationship of an upper teeth posterior with an lower counterpart, like this. We have that it's out of occlusion. In this case, what we should do is to add cross elastics that is stretched from the buccal aspect of the upper tooth to the lingual of the lower tooth, and we add bite blocks to provide occlusal clearance for the clearing the bite. That's it. Salam.